really happy to be back in Utah. Thanks to ACD for organizing the symposium and give me the opportunity to present today. It's the green one, huh? Right? Okay. So I must say that since the Paris Symposium end of September, there has been some exciting news, as you have heard from Aurore Curie and Thomas Joudinot. Today I'm going to focus on clinical trials and CTD girls. Just before, for people who don't know Xtraordinaire, it's a French-based non-profit patients association that has the particularity of reuniting multiple syndromes that have in common a very rare X-linked mutation with neurodevelopment disorders. CTD is the main syndrome within Xtraordinaire, with almost 80% of the French patients diagnosed. As you see on the slide, we have 84 CTD patients, 90% boys, 10% girls, and you can see the split by age. And we have also families with 2 siblings or 3 CTD children. So, first part, getting ready for clinical trials. So, given the promising research done by Ceres Brain, we have been very proactive in educating families ahead of clinical trials to get ready whenever it starts. The first step, Aurore Curie observational study, as you have seen. 2 years ago, when we were in Park City, we disclosed a survey showing that 52% of the families would be okay to enroll our study, and 44% were unsure. The result is that all the families that have been keen to be enrolled in our study, and the results are beyond our expectation. You saw with the MRI, for example. We believe that it is very important first step to show families that it's possible for their children to participate. We are also starting to educate and inform families of what would be a real clinical trials, encouraging them to ask questions and share their fears. It is interesting to see that before our study, most of the parents were wondering, will my child be able to perform tests, MRI, etc.? And now almost none of the family are asking questions about that because they saw that their children were not only able to perform most of the tests, but they did much more than they were expecting. They also saw that the hospital and the medical team have done a tremendous work to make things easy and smooth, which was very important. The most question we have now on trials are, will my children be eligible for the trial? What if the treatment doesn't work? What if there is some side effects? So the question about side effects and non-efficient treatments are very legitimate. What if there is toxicity on a human brain? How can we monitor that? Would it be reversible? What if the treatment doesn't work? Moving from an exciting and motivating trial with a lot of attention and care to go back to before with no more hope, there are keys for the families. So we're planning a couple of virtual meetings with Q&As in order to address those questions and fears. We strongly believe that being proactive is key. On the application and inclusion criteria, and the selection of core outcomes, as you heard from Aurore, we'll hope to have more information soon, and we will target the families that will fit into those criteria. So moving to the girls with CTD. So for the people that attend the Paris Symposium in September, we have a big session on girls, and we have conducted an international survey that included 21 CTD girls. We have compiled a lot of data that should be published soon, an official publication. As you can see, the survey included girls from age 3 years old to 48 years old. And we had a quick recap on the key findings on the slide. So you see the most common symptoms before diagnostics, the main development milestones, the behavioral issues, epilepsy. So mainly the same type of symptoms that you could see in male, and with different, milder to tougher symptoms. So you have more details here, slides to show on different questions that were asked to the girls' family on the autonomy, on socialization, on motor skills, on learning skills. I can send that to whoever wants to have them and more details. So while things are getting a bit better in educating the doctors, researchers, we have still a long way to go, and we believe it's important to advocate for girls. It is fair to say that in most of the stories, path to diagnostic has been painful, as the professionals are not enough educated to look at X-linked syndromes on girls. Also, as urine and blood testing creatine levels are not meaningful for girls, it is a long journey for families to get DNA or genome sequencing or MRI. Today, girls represent only 10% of CTD patients, but as mentioned earlier, the difficulty of diagnosis combined with a reluctance from doctors to perform DNA or genome screening may explain this low percentage. We also cannot accept to hear any longer less likely, milder symptoms, less severe. In our survey, we have a few girls with milder symptoms, but also have a dozen with very severe ASD or behavioral problem or epilepsy. And it is the same with boys with CTD. All difference with milder to tougher symptoms. We believe that it's important to have studies and publication about girls. Even animal models are male, at the exception of maybe a female rat of Olivier Bresson in Switzerland. But still, it's a long journey for us. So how can we improve visibility? Like in September in Paris and today in Salt Lake City, you doctors, researchers must remember that those girls deserve your attention, inclusion to your studies and trials, that despite difficulty of diagnosis, a diagnosis is a life-changing for the families. Our questionnaire survey will be out soon, and we are happy to announce that Aurore Curie, with the support of Xtraordinaire, has applied for a grant to extend her study to girls with CTD. So we should get an answer soon, so hopefully next year we can start to do the same for the girls. So please remember the girls and make them more visible. And last but not least, with some news from Italy, with the creation of the Italian Association for Creatine Deficiency, launched by two families. As you can see, they did a few events this year. They just launched their website, Facebook, Instagram. And so if you can share the word, I think they'll be happy to have, some followers and some advertising within Italian-speaking families and patients. Thank you all.
Thank you, Carole. Any questions for Carole? Sangeeta.
Actually, this is maybe more of an open question for the room, because I do think what Carole said resonates with most of us in the room. And I wanted to hear from some of the experts here, particularly those who interact with FDA and maybe other regulatory agencies in other countries. What is the stance of the regulatory agencies on, for these types of disorders, on including females from the get-go when the data is not completely sufficient? Is there more support? Is there room for advocacy with these regulatory agencies?
I want to say that in Canada, the funding agency equivalent to NIH is called CIHR. And now all CIHR grants, all researchers and applicants have to do a sex and gender analysis study or course. They have to submit the application, and they have to submit a separate section that have they included sex and gender in their study or not. That's part of the CIHR. And similarly, the Health Canada is approaching the same way, that you have to include, if the studies are not done, you have to include why it was not done.
Thank you. Anyone else?
The same that happens in Canada happens in the United States. However, what happened that in general, for many of the diseases that are X-linked, you try to analyze the population that are part of the clinical trial separately. Because, for example, in females with other X-linked disorder, there is much more variability than in males. For example, Fabry disease is the typical disorder that we study and we treat in the genetic clinic. And male are almost 100% sure to follow the same identical exact path. Female, obviously, you have females that are totally unaffected, and females that are mildly affected, and females who are more severe affected. So obviously, since you have all of these possibilities, when you mix the patient together in the study population, you start widening the variation among individuals. So demonstrating an effect becomes impossible unless you separate the population at least for analysis. In general, for the proof of concept, at the beginning they enroll only the patients who are, let's say, the most affected. And then they need to expand the population to all gender and including female. One note that I wanted to make is the fact that we have to consider the number of females with this condition is twice the number of male. It is clearly underdiagnosed. And what we need to do, and the problem is that the diagnosis is not as simple as in males. The decrease in the creatine peak might be minimal. The second thing is that even the urinary study can be totally normal. So one needs to go gene first. And that's what people are doing now. So we are getting there. Just be patient. I mean, obviously I understand it is tough, but because there is no other way around. And the only way is going gene first. And that's where we are getting.
Thank you.
Any other questions for Carole?
Thank you.
Thank you.